Inside hospitals across the United States, deaths are expected, but not all of them are understood. In some cases, patients under constant supervision declined without warning, records were incomplete, and key details quietly disappeared from official reports. These incidents were documented, reviewed, and then left unresolved. In this video, we'll break down 5 unexplained deaths that occurred under medical supervision. On the morning of April 17, 2014, 52-year-old Michael Turner was listed as stable in the cardiac recovery unit of St. Vincent Hospital in Indianapolis, Indiana. He had been admitted 3 days earlier after experiencing mild chest pain while at work. Initial evaluations showed a partial blockage in one coronary artery, and he underwent a routine angioplasty procedure later that evening. According to surgical notes, the procedure was completed without complications. By the following day, Turner was alert, responsive, and able to sit up unassisted. Nurses recorded normal vital signs throughout his recovery period, and his attending physician, Dr. Alan Reeves, noted in his chart that the patient was progressing as expected and could likely be discharged within 48 hours. Turner was assigned to room 312, a monitored recovery room equipped with continuous cardiac telemetry. The system tracked heart rhythm, oxygen saturation, and blood pressure in real time, with alerts configured to notify staff of any irregularities. According to hospital protocol, data from the monitor was automatically logged into the patient's electronic record every 5 minutes. Nurses also conducted manual checks at scheduled intervals. On the night of April 16th, the logs showed no abnormalities. At 11:45 p.m., Nurse Carla Jennings recorded that Turner was resting comfortably, with stable vitals and no complaints of pain or discomfort. At 2:12 a.m., a routine automated entry was logged into the system, indicating a heart rate of 68 beats per minute, oxygen saturation at 97%, and normal blood pressure. No alerts were triggered. At 2:17 a.m., a code blue was called from room 312. When staff arrived, Turner was unresponsive. The monitor displayed no active readings. According to the incident report, the leads were still attached to his chest, and there were no visible signs of distress in the room. Resuscitation efforts began immediately. CPR was administered for 18 minutes, followed by defibrillation attempts. At 2:39 a.m., Turner was pronounced dead. What drew attention during the internal review was the absence of any recorded warning signs in the minutes leading up to the collapse. The telemetry system, which was designed to capture even minor irregularities, showed a complete gap between 2:12 a.m. and the moment the code was initiated. There were no gradual changes in heart rhythm, no spikes or drops in oxygen levels, and no alarms logged. The data simply stopped. Technicians later confirmed that the system itself had not malfunctioned that night. Other patients on the same floor had continuous, uninterrupted recordings. Dr. Reeves reviewed the case later that morning and noted the sudden nature of the event. In his report, he wrote that Turner's condition did not suggest an imminent cardiac arrest. There were no indications of clot formation, internal bleeding, or post-procedural complications. A preliminary cause of death was listed as sudden cardiac event, but no specific mechanism was identified. The family requested an autopsy, which was conducted 2 days later by the Marion County Coroner's Office. The autopsy findings did not provide a clear explanation. There was no evidence of a new blockage, no rupture, and no signs of pulmonary embolism. Toxicology results were negative for any substances outside of the medications administered during his hospital stay. The report concluded that the cause of death was undetermined, citing the lack of physical findings that could explain the rapid deterioration. Further questions arose when reviewing the medication administration records. At 1:50 a.m., Turner had been given a standard dose of a blood thinner as part of his post-procedure care. The dosage and timing were consistent with protocol. However, the electronic log showed a brief delay in synchronization between the nurse's entry and the central system. While this discrepancy was noted, it was not considered significant enough to impact the outcome. No additional medications were recorded between that time and the collapse. Nurse Jennings, who had last checked on Turner, stated during the review that he appeared calm and oriented. She reported no signs of distress, confusion, or discomfort. When asked about the 5-minute gap in telemetry data, she confirmed that she had not adjusted or disconnected any equipment. Maintenance staff later inspected the monitoring unit and found no faults. The leads were tested and confirmed to be functional. Security footage from the hallway outside room 312 was also reviewed. Between 2 a.m. and 2:20 a.m., no one was seen entering or exiting the room. The door remained closed, and there were no interruptions in the corridor. Inside the room, there were no cameras. The hospital stated that patient privacy policies did not allow for internal surveillance in recovery rooms. The case was discussed during a hospital morbidity and mortality conference later that month. According to meeting notes, several physicians expressed concern over the lack of telemetry data during a critical window. One participant noted that even in cases of sudden cardiac arrest, monitors typically capture at least a brief period of irregular activity. The absence of any recorded transition was described as atypical. Despite these concerns, no formal conclusion was reached. Turner's family pursued further clarification through legal channels, requesting access to all internal reports and system logs. Some data was provided, but portions of the telemetry records were listed as unavailable due to system overwrite. The hospital maintained that all relevant information had been disclosed and that there was no evidence of negligence or equipment failure. In the years that followed, the case received limited attention outside of internal discussions. No additional findings were reported, and no changes were made to the hospital's monitoring protocols as a result of the incident. The official cause of death remained undetermined. The 5-minute gap in telemetry data was never explained. On September 9, 2016, 2 patients were assigned to room 214 in the step-down unit of Mercy Hospital in St. Louis, Missouri. The room was designed for patients who required close monitoring, but were no longer considered critical. Both occupants, 68-year-old Richard Halpern and 72-year-old Leonard Briggs, had been admitted for unrelated conditions. Halpern was recovering from a minor stroke and was undergoing observation for blood pressure stabilization. Briggs had been admitted 2 days earlier with a severe respiratory infection that was responding to antibiotic treatment. According to medical records, neither man was considered at immediate risk of death. Nursing logs from the morning shift indicated that both patients were alert and stable. At 8:30 a.m., Nurse Daniel Ortiz recorded that Halpern was oriented and able to speak in full sentences, while Briggs was breathing without assistance and showing improved oxygen levels. Their vital signs were within acceptable ranges, and no emergency interventions were anticipated. The attending physician, Dr. Melissa Grant, noted during her rounds that both patients were progressing appropriately and did not require transfer to intensive care. At approximately 11:10 a.m., a routine check was conducted by a nursing assistant, who later reported that both patients were resting. No irregularities were observed. At 12:02 p.m., a code blue was called for room 214. When staff entered, Halpern was found unresponsive in his bed. The cardiac monitor showed no pulse. Resuscitation efforts were initiated immediately, including CPR and administration of emergency medications. Despite these efforts, Halpern was pronounced dead at 12:26 p.m. Briggs, who remained in the adjacent bed separated by a curtain, was awake during the initial response. According to Nurse Ortiz, Briggs appeared confused but not in distress. His monitor continued to show stable readings and no immediate changes were recorded. After Halpern's body was removed from the room at approximately 1:05 p.m., Briggs was reassessed. His vital signs remained within normal limits, though staff noted a slight increase in heart rate, which was attributed to the earlier disturbance. At 2:41 p.m., less than 2 hours after Halpern's death, a second code blue was called for the same room. This time, Briggs was found unresponsive. The monitor displayed a sudden loss of cardiac activity. Resuscitation procedures were again initiated, following the same protocol. After 22 minutes of intervention, Briggs was pronounced dead at 3:03 p.m. The proximity and timing of the 2 deaths prompted an internal review. Both patients had died under similar circumstances, with no prior indication of rapid decline. Initial assessments found no shared medications that could explain the events. Halpern had been receiving antihypertensive drugs, while Briggs was on antibiotics and supplemental oxygen. Their treatment plans did not overlap in any significant way. Autopsies were conducted by the St. Louis Medical Examiner's Office. In Halpern's case, the cause of death was listed as sudden cardiac arrest, with underlying vascular disease noted as a contributing factor. However, no acute blockage or hemorrhage was identified. In Briggs's case, the findings were less conclusive. His lungs showed signs of infection, but not at a level typically associated with fatal outcomes. The report listed the cause of death as undetermined, citing the absence of a clear physiological trigger. Attention then turned to environmental factors within room 214. Maintenance records showed that the room's ventilation system had undergone routine servicing 2 weeks prior. Air quality tests conducted after the incident did not reveal any contaminants or irregularities. No alarms or equipment malfunctions were reported on the day of the deaths. The cardiac monitors for both patients were tested and found to be functioning correctly. Staff interviews were conducted over the following days. Nurse Ortiz stated that he had never encountered a similar situation in his 10 years of experience. He described both patients as stable and cooperative during his shift. When asked about any unusual observations, he mentioned a brief moment before Halpern's collapse when the monitor displayed a flat line without prior warning. He noted that there was no transition, no gradual decline, and that the reading changed abruptly. Other staff members reported no anomalies. The nursing assistant who had last checked on the patients before the first code confirmed that both men appeared to be resting normally. No medications had been administered in the hour leading up to Halpern's collapse. Security footage from the hallway outside room 214 showed no unauthorized entries or unusual activity during the relevant time frame. One detail that remained unclear involved the telemetry data. Similar to Halpern's case, there was a brief gap in recorded data during the minutes leading up to each collapse. Hospital technicians reviewed the system logs and confirmed that the monitors had been connected and operational. However, the data files for those specific intervals were incomplete. The system did not register any errors, and other rooms on the same network showed continuous recordings. The hospital's internal review concluded that the deaths were coincidental and unrelated. No formal link was established between the two cases. The report stated that both patients had underlying conditions that could have contributed to sudden cardiac events, despite the lack of definitive evidence. No changes were made to hospital procedures, and the case was closed without further investigation. Families of both men requested additional information, but were informed that all available data had been reviewed. Portions of the telemetry records were no longer accessible, having been overwritten by the system's automatic storage cycle. No external investigation was initiated. Room 214 remained in use following standard cleaning and inspection. No further incidents were reported in that space. The deaths of Richard Halpern and Leonard Briggs were recorded as separate events, occurring on the same day, in the same room, under similar conditions. The absence of a clear explanation for either case was noted, but no connection between them was officially recognized. On June 3, 2018, 44-year-old Daniel Kessler was admitted to Cedars-Sinai Medical Center in Los Angeles, California, for a scheduled laparoscopic gallbladder removal. The procedure had been recommended after several months of intermittent abdominal pain caused by gallstones. Kessler had no significant medical history beyond mild hypertension, which was controlled with medication. Preoperative evaluations showed normal cardiac function, stable blood work, and no contraindications for surgery. According to intake notes, he was considered a low-risk candidate. The surgery began at 9:14 a.m. and lasted approximately 75 minutes. It was performed by Dr. Irene Walsh, a senior surgeon with over 15 years of experience. The operative report described the procedure as uneventful, noting minimal blood loss and no complications. The gallbladder was successfully removed, and all instruments were accounted for at the conclusion of the operation. Anesthesiology records indicated that Kessler responded normally to sedation and was extubated without issue. By 11:05 a.m., he had been transferred to the post-anesthesia care unit. Recovery room notes show that Kessler regained consciousness within 20 minutes. He was alert, able to respond to questions, and reported only mild discomfort at the incision sites. His vital signs remained stable throughout the afternoon. At 2:30 p.m., he was moved to a standard recovery room on the surgical floor. Nurses documented routine checks at regular intervals with no signs of distress or abnormal readings. At 6:45 p.m., Nurse Emily Vargas recorded that Kessler had eaten a small meal, walked briefly with assistance, and was resting comfortably. At 10:12 p.m., a final set of vitals was logged for the evening. His heart rate was 72 beats per minute, blood pressure was within normal limits, and oxygen saturation remained steady at 98%. No pain beyond expected post-operative soreness was reported. Kessler was not connected to continuous cardiac monitoring, as his condition did not warrant it under hospital protocol. Instead, standard overnight observation procedures were followed, including scheduled nurse rounds every 2 hours. At 12:05 a.m., a nurse conducted a routine check and noted that Kessler appeared to be asleep. His breathing was described as regular and there were no visible concerns. No further entries were made until 2:18 a.m., when a nurse entered the room for the next scheduled check. At that time, Kessler was found unresponsive in bed. According to the incident report, he was lying on his back with no signs of movement. A rapid response was initiated, followed by a code blue. Resuscitation efforts began within minutes. CPR was administered, and emergency medications were delivered according to protocol. After approximately 25 minutes of continuous intervention, no pulse was restored. Kessler was pronounced dead at 2:47 a.m. The sudden nature of the event prompted immediate review by hospital staff, as there had been no prior indication of deterioration. An internal investigation was launched later that morning. Dr. Walsh reviewed the surgical report and confirmed that there had been no complications during the procedure. Anesthesiology staff also reported no irregularities in drug administration or patient response. The medications given post-operatively were standard and within appropriate dosage ranges. No contraindications or allergic reactions were documented. The Los Angeles County Department of Medical Examiner Coroner conducted an autopsy 2 days later. The examination revealed no evidence of internal bleeding, organ damage, or surgical error. The incision sites were intact, and there were no signs of infection. Toxicology results showed only the presence of prescribed medications, all within therapeutic levels. No foreign substances were detected. The final autopsy report listed the cause of death as undetermined, noting that no anatomical or toxicological explanation could account for the sudden cardiac arrest. There was no evidence of pulmonary embolism, which is sometimes associated with post-surgical complications. Cardiac examination did not reveal structural abnormalities or signs of acute infarction. The report stated that the available findings do not identify a definitive cause of death. Attention then shifted to the timeline between the last recorded observation and the discovery of Kessler's condition. The 2-hour interval between checks was consistent with hospital policy for low-risk patients. However, some staff questioned whether continuous monitoring might have detected early signs of distress. No such monitoring had been ordered, and there was no indication at the time that it was necessary. Electronic medical records were reviewed for discrepancies. All entries appeared consistent, with timestamps aligning across departments. However, a minor irregularity was noted in the system logs. A brief delay in data synchronization occurred between 11:58 p.m. and 12:03 a.m., affecting several patient records on the same floor. Hospital IT staff later confirmed that the delay was due to routine server maintenance and did not result in a data loss. No additional entries were made for Kessler during that window. Security footage from the hallway outside Kessler's room was examined. Between midnight and 2 a.m., no unauthorized individuals were seen entering or exiting. Nursing staff were observed conducting routine rounds, and no unusual activity was reported. Inside the room, there were no cameras due to privacy regulations. Interviews with staff involved in Kessler's care did not reveal any concerns. Nurse Vargas stated that the patient had been cooperative and showed no signs of anxiety or confusion. The night shift nurse who discovered him unresponsive reported that the room was undisturbed, with no signs of struggle or movement. Medical equipment remained in place, and there were no indications of external interference. Kessler's family requested a second review of the case, including independent analysis of the medical records. While some procedural questions were raised, no definitive cause of death was identified. The hospital maintained that all protocols had been followed and that there was no evidence of negligence. The case was eventually closed without further action. Daniel Kessler's death remained classified as undetermined. The absence of complications, both during surgery and in the immediate recovery period, was noted in all official reports. No explanation was found for the sudden and fatal event that occurred during the night. On February 11, 2019, 63-year-old Evelyn Harper was admitted to Mount Sinai Morningside Hospital in Manhattan, New York, after experiencing persistent dizziness and episodes of fainting. Her medical history included controlled type 2 diabetes and mild arrhythmia, but no recent complications. Upon arrival, she was alert and able to describe her symptoms clearly. Initial assessments suggested a possible cardiac rhythm irregularity, and she was placed under observation in a monitored telemetry unit on the 6th floor. Over the next 24 hours, Harper underwent a series of routine tests, including blood panels, an electrocardiogram, and imaging scans. Results showed no acute abnormalities. Her heart rhythm appeared stable under monitoring, and her blood sugar levels were within expected ranges. On the morning of February 12th, attending physician Dr. Laura Chen noted in her report that Harper's condition was stable with no immediate concerns and recommended continued observation before discharge. Harper was assigned to room 618, a semi-private room equipped with continuous cardiac monitoring. Nursing staff conducted regular checks, and all entries in her electronic chart indicated consistent, stable vitals throughout the day. At 7:40 p.m., Nurse Anthony Delgado documented that Harper had eaten dinner, taken her prescribed medications, and was resting in bed. No additional medications were scheduled for the remainder of the evening. At 9:15 p.m., a medication entry appeared in Harper's electronic chart, indicating that she had been administered 2 milligrams of hydromorphone, a potent opioid typically used for severe pain management. The entry was time-stamped and marked as completed, with a digital signature attached. However, according to both her treatment plan and nursing notes, Harper had not reported any pain that would warrant such medication. Hydromorphone had not been prescribed at any point during her stay. Approximately 25 minutes later, at 9:41 p.m., a nurse responding to a monitor alert entered room 618 and found Harper unresponsive. Her oxygen saturation had dropped rapidly, and her breathing was shallow. A rapid response team was called, followed by a code blue. Emergency interventions were initiated, including assisted ventilation and administration of reversal agents. Despite these efforts, Harper was pronounced dead at 10:08 p.m. The unexpected death triggered an immediate internal review. Dr. Chen stated that the administration of hydromorphone was not part of Harper's treatment plan and that she had not authorized its use. Nurse Delgado, who had been assigned to Harper during the evening shift, denied administering the medication. He stated that he had not entered the room between his 7:40 p.m. check and the time of the emergency call. The electronic medical record system was examined to trace the origin of the medication entry. The digital signature attached to the hydromorphone administration was linked to Delgado's login credentials. However, Delgado claimed that he had not accessed the system during that time frame. System logs confirmed that his credentials were used at 9:14 p.m. from a workstation located near room 618. No other staff members reported using that terminal during the relevant period. Further analysis revealed that the medication dispensing system had recorded the removal of 1 vial of hydromorphone at 9:12 p.m., accessed using Delgado's identification badge. The dispensing unit required both badge access and a personal identification number. Delgado stated that he had not used the machine that evening and suggested that his badge may have been used without his knowledge. Hospital policy required staff to keep badges secured at all times. Surveillance footage from the medication room showed a figure entering at approximately 9:11 p.m. The individual was wearing standard hospital scrubs and a surgical mask. The camera angle did not capture the person's face clearly. The footage showed the individual accessing the dispensing unit and leaving within 2 minutes. No other staff were present in the room at that time. The identity of the individual was not confirmed. The autopsy conducted by the New York City Office of Chief Medical Examiner identified the presence of hydromorphone in Harper's system at levels consistent with recent administration. The report concluded that the cause of death was acute opioid toxicity. No other substances were detected. The findings were consistent with respiratory depression caused by the drug. Interviews with staff on duty that evening did not produce a clear explanation. Several nurses reported being occupied with other patients during the time in question. No one recalled entering room 618 between 7:40 p.m. and 9:41 p.m. The patient in the adjacent bed stated that she had been asleep and did not observe any activity. The hospital's internal investigation focused on potential security breaches within the medication dispensing system. IT specialists reviewed access logs and confirmed that Delgado's credentials were used for both the medication withdrawal and chart entry. However, no evidence of system hacking or external intrusion was found. The possibility of credential misuse by another staff member was considered but not substantiated. Delgado was placed on administrative leave during the investigation. He maintained that he had not administered the medication and had no knowledge of how his credentials were used. A review of his prior work history showed no disciplinary actions or irregularities. After several weeks, he was cleared of direct involvement due to lack of evidence, though the source of the medication order remained unidentified. Harper's family requested a full disclosure of the investigation findings. While the hospital provided documentation, certain details related to internal security protocols were withheld. The case was not referred for criminal prosecution, as no individual could be definitively linked to the administration of the drug. The incident led to a revision of badge access policies and additional monitoring of medication dispensing units. Despite these changes, the central question remained unresolved. Evelyn Harper received a medication that had not been prescribed, administered by an unknown source using credentials that could not be definitively attributed. The origin of the order was never determined. Thank you for staying until the end, where each unanswered detail lingers quietly, reminding us that truth is not always found in records or voices, but sometimes in what remains unspoken, buried beneath time, memory, and the weight of silence.